They are more than hospitals. They really are small cities, and they take a good-sized bite out of our healthcare dollar pie. Joining us now, the CEOs of 4 of Ontario's largest hospitals. Dr. Bob Bell, President and CEO of the University Health Network. Dr. Barry McClellan, President and CEO of Sunnybrook Health Sciences Centre. Mary Jo Haddad, President and CEO of the Hospital for Sick Children. And Dr. Robert Howard, President and CEO of St. Michael's Hospital. Great to have you 4 here with us in the studio today. And before we go any further, on this side of the table, I have to confirm what I just heard in the last interview. You 2 are both from Windsor, is that right?
Sure are.
Okay, did not know that.
Proud of it, Steve.
From Windsor. And do you have any particular connection to Sandra Pupatello, Mary Jo, that I need to know about here?
Well, we were neighbors.
Yeah.
Actually, we lived across the street from each other.
And?
Actually, I babysat for her.
You babysat her. I thought I heard that right. Okay.
I did. It's true.
All right. Having confirmed all of that, let's put into perspective some of what you do. If we can control them, let's bring these first couple of graphics up. The number of public hospitals in the province of Ontario is 149. They spend $23.4 billion, but 16 hospitals comprise about half of that expenditure. And here's the list. We're not quite Dave Letterman here, so we're not going to do a top 10. We're going to do a top 8. Bob Bell, there's yours. Number 1, University Health Network. We go down from Hamilton, Ottawa, London. There's Sunnybrook. Barry, that's yours. Trillium Health Centre, Hospital for Sick Kids, Mary Jo. And the other, Bob, there's St. Mike's Hospital there. So we've got 4 of the top 8 hospitals in the province represented here today. And I want to start, let's just go around and have you tell us very briefly what makes your hospital distinctive.
Well, Hospital for Sick Children's been around for a long time, 1875. It's distinctive in that it's the largest pediatric academic center in Canada. It's distinctive because it's had a research enterprise for over 60 years. So the underpinning of the way we do what we do is really anchored in research. And incredibly unique in that we are focused on, and have been for a very long time, family-centered care. So the child and family at the center.
Gotcha. Bob Howard, St. Mike's.
St. Mike's has become an academic hospital with emphasis on research and education, but we've still, from a patient care point of view, made a priority those who are less fortunate, disadvantaged. Added to that, a tertiary care focus on critical care and some specialty programs.
Bob Bell.
Steve, UHN goes back to the War of 1812, actually, formed just after that. We're 4 hospitals: Princess Margaret Hospital, Toronto General, Toronto Western, and Toronto Rehab, the most recent member of the UHN family. In addition, as you've pointed out, to being the hospital with the largest budget, looking after the most acute inpatients and rehab patients in the province, we're also proud to be Canada's most research-intensive hospital. So our budget includes about $300 million a year in research expenditures. And as is the case with Sick Kids and our other partner hospitals around the table here, we're very proud to be part of the Ontario Research Hospital enterprise community that's really trying to bring the best new information from our labs into practice so that we can benefit not only patient care, also the cost effectiveness of patient care.
Barry, Sunnybrook.
There's been quite an evolution. We are a very robust academic health sciences center, and we'd be somewhat differentiated by our very significant focus around critical injury and illness. Sunnybrook was the first trauma center in Canada. It's the largest trauma and burn center in the country. And we're very much focused on other areas of critical illness, including cancer, image-guided heart and stroke care, as well as high-risk mothers and babies.
Let's put some more numbers up here just again to give people a sense of the kinds of budgets you folks are in charge of. For example, University Health Network deals with $1.8 billion of annual budget. Sunnybrook, almost a billion. Sick Kids, $725 million. St. Mike's, $627 million. Those 4 hospitals account for 2/3 of the total budget of the 17 hospitals that are in the so-called Toronto Central Local Health Integration Network. So let's start with this. Why do you need all that money? Bob Bell.
So, Steve, I think it's important to recognize the $1.8 billion is not just money for patient care. As I mentioned, it's also money for research. Of our 13,000 plus employees, physicians, and volunteers, about 3,500 of those folks are researchers. So actually one of the premier health science research enterprises in the country, one of the best in North America, is actually operating within that budget allotment.
Bob, what do you need all that money for?
Well, we, as Bob has said, we're a research and an education as well as patient care hospital. So we have a fairly broad agenda. On the patient care side, we not only look after the catchment of Southeast Toronto, but like the other hospitals, service many patients from well beyond the GTA. So we have a helipad on the roof, and patients are being transferred every day from as far away as Oshawa and up South Lake in Newmark and west of St. Catharines.
I'm afraid to ask. Orange helicopters?
They're all orange helicopters,
Orange
that's correct.
Okay, just checking. I presume the need to keep up with whatever the absolute latest in technology is also drives those numbers a lot. Is that right?
There's no question, as an academic center where you're really pushing the envelope on discovery, on new treatments, on new ways of caring for patients, that the cost of that is embedded in some of the budgets that hospitals like ours all have, no question.
How about it?
Well, we can't do what we're doing without it. And of our 900 plus million, just under 600 million of that is directly from the Ministry of Health, and we have multiple other sources, including over $100 million of research funding. Our vision is to invent the future of healthcare, and quite frankly, we can't do it without that significant investment.
We should point out that you guys, of course, get money from the Ontario Ministry of Health, but also from private donors, and also from the federal government, I guess, for research dollars. Bob?
Steve, let me bring that back to the issue that you described about technology. One of the important things we do, especially here in Toronto, where we have the opportunity to have wonderful foundations that we're really dependent on, is to use some of that philanthropic support for investments in new technology and to determine not only is that technology effective, is it actually cost effective in the Ontario environment? And we think that we're performing that important function for the entire healthcare system of Canada, realistically, in our publicly funded system. What impact can this technology make? Being able to do that with philanthropic dollars rather than government capital is an important contribution.
I suspect everybody at this table, if you haven't read Jeffrey Simpson's newest book, certainly know about Jeffrey Simpson's newest book called Chronic Condition. He was in here a few months ago talking about the fact that Canadians seem to want to pay Cadillac prices, but in his view are getting a Chevy in return. That was one of the main points he made in his book, that the outcomes in the healthcare system are not what we're paying for. We should be getting more and better. Bob Howard, do you want to tackle him on that, or is he right?
Well, I think he has a point, but I don't know that he's got it completely right. The data that he's looking at from the Commonwealth Fund data suggests that Canada doesn't perform that well. I think if you actually break the data down, Ontario does actually much better as a province in Ontario. So we're actually leading the way in many of the areas. A big player in that data is whether or not you have electronic medical record. And if you don't, you can't score well. And if you do, you can score well. We're behind in Canada in general in that regard, and I think what I can say in Ontario, however, is we're making a big push forward, and we're ahead of all the other provinces, and we've got a big commitment to that. So I think you're going to see some of that data move in the future as we get increased density of electronic medical record across the province.
Mary Jo?
I think we also have, some of the best outcomes anywhere in the world. I can certainly reflect on health outcomes in cardiac care in Ontario and Canada. Internationally, we're at the top of our game. So I think his point is on systems and improving systems, and we have some exemplary system leaders here in Ontario, and I think some of us are sitting around your table.
Barry?
So I think that Mr. Simpson makes a number of important points. I don't agree with all of them. I don't necessarily agree with the shift towards private funding, but one area where I certainly agree is that we could do better with the total dollars that are available, and especially when it comes to more integrated care and more resources outside, quite frankly, of hospitals in order to do a better job as a system.
What's, Bob Bell, the biggest challenge in running your university health network given the following? We're spending a lot of money on healthcare already, and people don't want to pay higher taxes, but they surely want to have the best possible care anywhere in the world. Medicare is seen as the third rail of politics. You touch it, you get zapped. Politicians are loath to try to go there. The notion that there are external pressures on you guys 24/7 to do any number of different things. What's the hardest part about running that kind of world?
Steve, I'm going to go back to the word that Barry used, and that word's integration. How well do we integrate our services into the community, and how well is the community ready to accept the excellent care provided in Ontario hospitals? And this is an issue. There's no question there's capacity in our system that's taken up by patients who are in hospitals, who are in environments that aren't really needed for the care that they're requiring at the present time. How do we make sure that the right patient is being treated in the right environment, the right, most cost-effective environment at all times? Integration of services is what provides that. And something the four of us around this table are very interested in the Toronto Central LHIN, trying to bring our services into the community, making sure we can shake hands with folks as patients are discharged, ensuring those patients aren't going to be returning to us because of a lack of primary care resources. And I think we're recognizing that's the kind of resource that we need. Not more money, but more integration of activity, integration of information, and structures that actually bring our care points together.
Well, you tell me this, because one of the things I hear is that so much of, never mind the hospital world, the whole world, all of government, happens in silos. And people don't talk to each other. And you run your silo, but you're sort of ignorant of what's happening over here in this silo here. How much of that happens in your world?
You know, I would say to you, there's more collaboration and integration in my hospital between departments, between professions, between our hospital and our partner hospitals on University Avenue, but also between our care providers and the community providers, our care providers and those who we want to ensure that we're sharing information and knowledge so their kids are cared for in their local communities. So silos are part of the problem, and I think there's a tremendous effort underway for the last 5, 6, 7 years to take those down. We're not where we need to be.
Barry, my assumption would be that if you four sat in a room for a few hours on a Sunday afternoon, you could kind of solve half the problems in healthcare today because you control such an enormous part of the healthcare budget. So do you actually get together?
Oh, we get together very frequently.
You do, the four of you.
And you know, there's a myth out there that there's this unhealthy degree of competition between hospitals and they're fighting for resources and not working together. I think it's an unusual week where the four of us wouldn't be in the same room twice and not talking about how we can do better within our own four walls, but how we can do better for the system. And as Mary Jo said, that goes you know, beyond just hospitals cooperating with one another. That's the entire system, primary care, right through to institutional care, right through to aftercare. So we actually spend quite a lot of time working on improving the bigger system.
Can you give me a for instance on how that might work with the four of you in the room, and what are you divvying up or how are you solving problems? Tell me how it works.
Well, I'm not sure we're divvying up, but we certainly work together on initiatives, and there are a number that I guess we've put together over time. Well, for instance, Barry said to you that he has a major trauma program, largest trauma program in Canada. So St. Mike's is the second largest trauma program in Canada, and we partner on trauma programs. We service the GTA and beyond for trauma care. So we have to work together to make that seamless and to work well. We have other examples with Toronto General where we partner on vascular surgery. So we have a regular call system that one night St. Mike's is on call for vascular surgery, and the next night Toronto General is on call for vascular surgery, and we cover all of the emergencies 365 days a year that come out of that, and that doesn't happen by accident. I mean, we have groups that meet regularly to make sure that that's working well and we're providing the best possible care.
Let me then, Mary Jo, let me go for a more nefarious example then. Let's say the government of Ontario in its wisdom wants to create a new $75 million study in some aspect of children's care. And, you know, there's the Premier from Ottawa, and he's got Children's Hospital of Eastern Ontario, CHEO, and if not in his riding, then certainly in his city. And there's you, and you're the, you know, largest in the country, world renowned of what you do, but you both can't have the grant. Someone's going to get it. Isn't that a case where people are competing over healthcare dollars and their gain is your loss?
So you're making an assumption, though, that we're not working with CHEO, as an example. So I think part of what happens in healthcare is that we all have an expertise. So if we're talking about children's hospitals, I'm doing research CHEO's doing research. Are we doing the same research? We shouldn't be. And if we are, then how do we collaborate together? So there's a tremendous amount of collaboration on the research front, collaboration on programs. I chair, for example, the Provincial Council for Maternal Child Health. We come around a table, all providers of children's health in the province, to talk about standards of care, to talk about where we need to drive improvements, where we should be studying that perhaps we aren't today. So I want to be in a position where I'm supporting the grant that CHEO gets to study whatever it is they need to study. That competition, there's something really positive about competition. Competition for the sake of being redundant and where dollars go is a problem.
Well, let me follow up with you on that, because the public may be under the assumption that you are competing as opposed to collaborating with other hospital systems around the country or the province.
So, Steve, you'll be delighted, your viewers will be delighted to know that UHN and the other partners around the table here have selected areas where we should be internationally excellent. So, for example, we don't do pediatric care, we don't do obstetric care at UHN. Mount Sinai, our partner across the street, has taken over all the deliveries. St. Mike's and Sunnybrook also do obstetrical care. We don't. We don't do trauma care. Whereas the areas we would focus in, multi-organ transplantation, neurosurgery, advanced cancer care, some of these areas are places where we put those resources in order to ensure that we can provide internationally leading care. And of course, with our close partner across Gerrard Street on University Avenue, the wonderful advances in pediatric care now result in the first generation of adults actually needing cancer care, cardiac care, as they advance from the pediatric age group. That's a great example of collaboration between hospitals as opposed to competition.
Barry, let me ask you this. Everybody who's funded by the provincial government, you, us here at TVO, we are all expected to do more with less. Are you as well?
You know what? We are. And we're providing more care. We're doing more research. And I think it's fair to say that that's something that's certainly not unique to healthcare, and it's not unique to hospitals within healthcare. Having said that, because we are working better together, I think we're doing a much better job of it. And, you know, Bob and Mary Jo were just talking about working together here in Toronto. I think it's worth emphasizing that across the entire province, the 24 academic health science centers meet on a regular basis through an organization here that is all about advancing research and working together to provide the most complex care. So this is not just a made in Toronto situation. We actually work very well across the entire province.
Okay. Jeffrey Simpson will make another appearance on our program right now through the following clip in which he's going to lay something out, and then I want to get you folks to respond to it. Control room, rotate, please.
The one thing that struck me is, what are hip and knee replacements being done in a hospital, fighting for OR space with neurosurgery and other complicated surgery? They should be in a clinic over here, run privately by the orthopods, who would organize the clinic. The access would be fast. The quality would be as good. The state would pay. The state would pay. It's a private delivery of a publicly paid service. And what's this system for? Is it for ideology or is it for patients? I say it's for patients, and I'm agnostic, frankly, on a lot of the points for which others take a deep ideological view.
Jeffrey Simpson from Chronic Condition. The suggestion, Bob Bell, is that we ought to be, tradition notwithstanding, doing a lot more procedures in the community, in smaller, faster, cheaper, more efficient facilities, and not in big, expensive hospitals.
Well, you know, Steve, I think Jeff's a little behind the times. He's missed out on some of the advances that have occurred in taking procedures within hospitals that used to keep patients in-house for a week and then send them to rehab hospitals afterward into far more streamlined ambulatory type procedures. So at the Toronto Western Hospital, for example, we actually do brain tumor surgery as an outpatient, following the patient up very carefully at home with nursing support in the community. Going back to Jeff's example of hips and knees, you know, we do hip and knee surgery in the ambulatory area, arthroscopy of the knee, but when it comes to hip and knee replacement, we're often dealing with people in their 80s. Quite often it's useful to have the cardiologists, the other consultants present in hospital to ensure that care for hip and knee patients is safe. If we look at the Alberta experience of trying to take care out of the hospital into a hip and knee center, it was actually an experience that ended up in bankruptcy. So perhaps we should learn from that there's lots of opportunity in our system for shortening length of stay, for streamlining patient care through patient education, These things are happening. When I was an orthopedic surgeon in active practice, my hip and knee patients would stay in hospital for 7 days. Today, the average patient is discharged after 3.5 days, with lots of education ahead of time, lots of follow-up in the community after they get home.
Okay, well, they're discharged quicker and sicker. That's one thing we hear too.
We'd say that they're discharged in an appropriate time, well prepared for what they need to do when they get home. The patient education that goes on prior to surgery, during the time patients are in hospital, and after they go home has been really well thought through. And the educated patient is one that's going to do well with his surgical procedure.
Barry, is there enough transformation happening in the healthcare system today so that procedures that don't have to be done in hospitals but can be done more efficiently, more cheaply in smaller centers, is that happening?
It's happening. There still is room for more of it to happen. You know, Bob talked about the fact that we're already seeing that transition, but you know, clearly when we look at procedures like cataracts, like endoscopy, more and more of that is going to be done outside of hospitals, and that's good for patients and it's good for our hospital resources. If I was to pick a procedure, I wouldn't land on hip and knee surgery first. So I agree totally with Bob. But you know what? There's a lot of opportunities out there, and there's a lot more room to go than we've gone so far.
Are there more opportunities for children? Because, you know, parents being parents, you know, probably want to go to a big fancy hospital if something's wrong with their kid.
Pediatric care has changed really dramatically, but a long time ago, almost 20 years ago, a huge shift from inpatient care to ambulatory care. At Sick Kids, about 400, almost 400,000 of my visits are ambulatory, and they're intense ambulatory. They're not the doctor's office type of visit. So what we know in pediatrics is children do better if they stay home, if they're cared for at home. So there's a lot of innovations that have occurred over time in providing services closest to home and on an ambulatory basis. At the end of the day, the challenge in pediatrics, somewhat unlike adult care, is a lot of the procedures that we give are under anesthesia because you need a child to not be moving and to cooperate. You need to understand their pain thresholds when they can't tell you things. So the care model is somewhat different, but first and foremost, and I think for both pediatrics and adult care, it's about safety and safety of the patient. And, you know, we have a lot of children and adults in our centers that have other problems besides perhaps a hip and knee or a cataract surgical requirement. So the comorbidity of those patients becomes very complex. Comorbidity. They have other issues besides the issue that they happen to be presenting in the hospital at that particular time. I'm
not meaning to pick on St. Mike's and asking you this question, Bob Howard, but one of the things we also hear is that hospitals are places you don't want to go if you don't have to go there. There's MRSA, superbugs, all sorts of bad things that can happen to you in the hospital, unanticipated. So if you don't have to have surgery there, better that you don't. Isn't that right?
So I would say that's true. If there's a way to do the surgery without an admission to a hospital bed, then you probably should. And just to add to it, we've moved a long way. St. Michael's has never had fewer beds than it has today and never cared for more patients than it does today. So how's that possible? Well, the answer is technology and new models of care have resulted in just totally different types of practice. So a lot of the surgery we do now is outpatient surgery. You can have your gallbladder removed now and not be admitted to a bed. So, you know, it used to be a week in hospital and 3 months of sore abdomen, you know, sore tummy afterwards. Now you don't get admitted and often back to work in weeks. So that's technology and new methods of doing surgery. So we're all there. We're all going there as fast as we can. Some of them initially are more expensive than the traditional models, but you know, we find ways to make them more cost-effective and move on because they're better for the patient.
That dovetails to my next question, which is if we can do more procedures outside of big, expensive hospital settings, can we get away with giving you guys less money?
So, Steve, I'm going to start off by challenging that we're expensive. Against what? Ontario Hospital's efficiency, the work that we've done towards streamlining care that we've discussed here today actually results in a per capita cost of hospital care to Ontarian citizens that's $200 less than the average Canadian cost. That's about a $4 billion premium to the taxpayer of Ontario. We certainly have further to go. We've talked about the fact that not every patient that's in hospital perhaps needs to be there. We need to improve our community resources to accept those patients to a high standard of care in the community. But certainly, we'd suggest that Ontario hospitals are working hard to make our care more cost effective, and that's showing up.
Okay, but
There's evidence of that.
having been said, let's take your numbers at face value. That having been said, it's presumably cheaper to do, I'm going to assume it's going to be cheaper to do a hernia at Shouldice than it is to do it on University Avenue. Is that right?
Steve, people stay overnight at Shouldice. They spend a couple of days admitted to hospital when they get their hernia done at Shouldice. They don't do that when they come into UHN, St. Mike's, or Sunnybrook for a hernia repair. They go home the same day.
So put the stereotypes out of my head. It ain't necessarily so.
I think you got to dig under the surface a little bit to see some of the changes that are happening in the Ontario hospital system.
Okay, let me go to you, Barry, then on, let's say, for example, Kensington. They do eyes, right? You need cataracts removed or something. Can you do cataracts more cheaply in a standalone facility that's in the community than you could in a hospital operating room, for example?
Right, so the answer is yes. And that's a great example where we want to see virtually all cataracts done in a center like Kensington. And in fact, see a center like Kensington taking on additional procedures that they may not be doing right now. There's other eye surgery that may be done in hospitals right now that could be done at Kensington. So that is a very important model. But there certainly are procedures, and we talked about hips and knees, which are better right now done in a hospital environment.
Are there, and Mary Jo, you're going to name names here. Are there dinosaurs in your system who insist that everything has to be done inside a hospital setting, period, full stop?
They're dinosaurs?
Yeah.
Absolutely not.
And I want their names. Give me their names. I want to invite them on.
You know, one of the exciting things about being in healthcare, and I really believe this. I've been in it for almost 40 years. I am incredibly proud of the people I work with. They want to make things better. They're challenging me and I'm challenging them, and at the end of the day, we do things better. I think what you're hearing today is in our system, there's room for change and improvement. We're up to the task. We're doing that every minute of every day. We're improving the way we use our resources. We're looking at new models of care. We're partnering, collaborating in ways that perhaps from a myth perspective never happened before. It's certainly happening every minute of every day, and I think change is afoot, and I'm excited by it.
Okay, Bob Howard, tell me if this is myth or reality. People think, I'm guessing, that they have to wait too long for surgical procedures, that the waiting lists in Canada, for some things, are too long. I wonder whether there's anything you, as people who run hospitals, can do about that.
So I would agree that actually people do wait for many things too long in Canada, and we actually have to do a better job. The way we deal with it right now, on working with a fixed budget, is through trying to make things more efficient and increase our what we would call throughput. Throughput is sort of numbers of patients, per unit of resource, or per bed, or per operating room, that sort of thing. So there are things we can do, and we are doing to improve that, the efficiency of that, if you like, in the operating room, moving from general anesthetics to traditional old general anesthetics that took you 2 days to recover, to anesthetics that the moment you wake up, you're ready to walk out of the hospital. Or actually not even using a general anesthetic, using a local anesthetic, just local freezing, so they're actually not asleep at all. All of those kinds of things actually start to give you opportunities for shortening length of stay, or actually avoiding totally a length of stay. And I've already talked about some of the minimally invasive techniques to surgery that are coming on board. So we need to adopt some of these new models to increase our throughput, and if we can, that'll free up some resource that allows us to do more cases sort of per day than maybe we used to do in the past.
With a few minutes left here, let me, doctor, not a doctor. Nurse. Let me, MBA?
MHSC.
MHSC. Is it, who runs hospitals better? People who used to be doctors, or people who have sort of administrative training in running big organizations?
So there's not a simple answer to that. I think having a clinical background gives you incredible grounding in what the frontline physician, nurse, caregiver faces every day. So there's a sensitivity that's an added bonus in running a very complex business. the business acumen, understanding how to make things work, leading people, leading change, managing complex budgets, and many stakeholders is equally important. So they come together. There's no question being a clinician helps a lot.
Bob Bell, is it at any way a disadvantage to have been a doctor who does the sort of hammer and chisel stuff that you used to do, if I can put it that way?
It didn't look like orthopedics today, Steve. That was
I hear you. I hear you.
So, you know, healthcare is an aspirational business. People want to help. They want to do better. They want to improve things. Understanding the aspiration of healthcare is the key thing to being a leader in healthcare, I think. Perhaps you get that from having a personal experience in frontline care as a nurse, a physiotherapist, a doctor. Maybe that comes more naturally, but certainly I've met people who are IT specialists, who are engineers, process engineers, who understand that passion that comes with healthcare. That's the most important thing.
Okay. In our last minute and change here, let me put one nasty little political thing on the table, and you probably all know what's coming here, and that is your salaries are all published. And we know one of the parties at Queen's Park, the NDP, have said there ought to be a cap on hospital CEOs' salaries because in their view, they're too high. You got a view on this?
I do. I mean, first of all, I think it's great that we've got transparency when it comes to executive compensation, but the compensation right now fits with the individuals who are doing the work. These are complex positions, something that you know, Bob didn't get into when talking about some of the other, I guess, complexities of the work is the academic piece and understanding the complexities of a research hospital and trying to grow a research enterprise. So I think it's great that it's transparent, but I believe that based on the leaders that are in the system and their major role in hospitals and beyond, that the compensation is in fact appropriate.
If you capped at 400 grand, what would happen?
You know, I'd still do my job, Steve. I love my job and I keep on doing it. I bet the people around this table would. You got to remember though, we don't set our salaries. Our boards set our salaries, and to bring in people like Bob Howard, who's a cardiologist, certainly to pay him what he'd be able to make doing his clinical work, the board of St. Mike's thinks that's a fair way to pay him what he's making today.
Gotcha. I want to thank all four of these hospital heavyweight CEOs for coming in tonight and helping us understand what goes on in your worlds. Thanks so much to everybody. Bob Bell from the University Health Network, Barry McClellan from Sunnybrook Health Sciences Centre, Mary Jo Haddad from the Hospital for Sick Kids, Bob Howard from St. Mike's Hospital. Thanks so much, everybody.
Support Ontario's public television. Donate at tvo.org.